My name is Dian Wulandaru Pertiwi. I represent a research team from Department of Child Health and Division of Pediatric Surgery, Cipta Mangunkusumo Hospital, Faculty of Medicine, University of Indonesia. I would like to present a preliminary study about risk factors for bacterial infection in children following liver transplantation in Indonesia. So for the session, I would talk about background, objective, methods, results, and discussion of the study, followed by limitation and conclusion. Survival rate and quality of life, or QOL, of children with chronic hepatobiliary disease has improved since the development of liver transplantation, or LT, within these 50 years. Post-LT complications can include infections, which becomes a frequent cause of morbidity and mortality, especially those related to medical devices. Incidence of viral infection is 39 until 79% at 6 months post-LT, with a mortality of 3 until 10.6% at 3 months post-LT. Several studies have identified risk factors for bacterial infections following LT in pediatric LT recipients that can be categorized based on the time of occurrence. Before operations, which is pediatric end-stage liver disease or PELT score, during operations, which are duration of transplantation greater than 12 hours and volume of blood loss, and after operations, which are length of stay in intensive care unit or loss in ICU, and biliary complications. Majority of those studies were conducted in developed countries. Data from developing countries are very limited, and currently no study from Indonesia. Yet, understanding various risk factors that can for bacterial infections can guide healthcare professionals in implementing the appropriate preventive measures. This is the first study in Indonesia to investigate the risk factors for bacterial infection in children who underwent liver transplantation. Our study is a retrospective cohort study that includes all pediatric living donor liver transplantation or LDLT recipients in Cipta Mangunkusumo Hospital or CMH between December 2010 until April 2023. The minimal sample size should have been 184 subjects, but our total pediatric LDLT recipients until April 2023 was only 65 patients. So we did total sampling method, and this is a preliminary study. Inclusion criteria is all pediatric liver transplant recipients age 0 until 18 years old. Exclusion criteria is incomplete data and mortality within 44 hours after LT. From all subjects, 2 were excluded, so the total study subjects are 63. We recorded the risk factors, bacterial infections, and mortality within 6 months. We got 55 subjects in bacterial infection groups and 10 subjects in non-bacterial infection one. Finally, all data was processed. With a note, there are 3 time periods of infection following LT, but we only focus on early period, which is within 1 month post-LT, and intermediate period within 1 until 6 months post-LT. We search all types of bacterial infections during hospitalization, whether it is related or unrelated to medical devices. This is the results and discussion. In the bacterial infection group, the median of age is 17 months with interquartile range of IQR of 12 until 23 months. 54% of them are male, and 54% of them has moderate malnutrition. Biliary atresia is the most common underlying disease, followed with cholelocystis, Alagille syndrome, and Carroll disease. Sex, age, underlying disease of the study population is similar to several previous studies. Half of the subjects in bacterial infection group used methylprednisolone or MP and tacrolimus, and 80% of subjects who got amphipoles were also had bacterial infection. In this group, rejection and relaparotomy happened in 35% and 35% respectively. We found difference in prevalent immunosuppressant and relaparotomy cause from previous studies, which were wound closure and intra-abdominal bleeding in Polarvat et al. CMS Center preferred surgical intervention to treat biliary complications, which mostly caused by biliary leakage. Mortality rate within the bacterial infection group is 15.10%, and all subjects with an outcome of mortality came from this group. Total mortality rate among all study subjects is 12.70%. Beranger et al. And Pichapov et al. Reported lower mortality. Beranger et al. Reported 10.6% in 1 month, and Pichapov et al. Reported 6.8% in 3 months. However, our mortality rate is not significantly different from Beranger et al., who conducted the study at the developed country in Paris. This finding indicates that the bacterial infection, HMH, can be diagnosed and managed effectively, thus preventing patients' mortality. On Wilcoxon test, we found C-reactive protein or CRP and procalcitonin or PCT has difference between pre and post LT. Post LT PCT is the only infection marker that differed between both groups in the study. The median post LT PCT in the bacterial infection group is 2.98 with IQR of 1.23 and 7.12. A prospective study in the UK found an increase in post-LT PCT with a median value of 1.93 ng per milliliter in 24 children with new fever episodes in the bacterial and fungal infection group. Post-transplantation PCT greater than 2 ng per milliliter with clinical signs of new infection may help diagnosing bacterial infection in children following LT. Prevalence of bacterial infection within 6 months following LT in CMH is 84.13%. There are 162 identified bacterial infections, and 70% of them happen in early period within 1 month post-LT. And our subject had 87% of our subjects also had multiple infections. Current study has higher prevalence of bacterial infection than previous studies by Polafar et al., which found 54% in 1 month. He conducted a study in Iran, and also Navadihego et al. In Japan, who found 51% in 3 months. Similar with the proportion of bacterial infections is similar to Fazen et al., but they reported lower co-infections in about 19%. Our high amount of bacterial infections in early period may reflect healthcare-associated infection or hospital-acquired infections, or we call it as HAI. HAI increases patients' morbidity and mortality, as well as the rate of MDR bacterial infections. CMH has bacterial infection evaluation pre and post pediatric LT protocol that already have been implemented well. The high rate of bacterial infection in study is estimated to be related to the low compliance of HAI bundles by healthcare professionals. However, there is no qualitative study about this aspect in CMH until current date. Surgical site infection or SSI is the most common infection, followed with ventilator-associated pneumonia or VAP, catheter-related urinary tract infection or CAUT, and bacteremia, and this finding supports previous studies. 82% of bacterial infection were caused by gram-negative bacteria and in line with bacteria that cause HAI. This also may be related to perioperative complications, especially during early period post-LT. The prevalence of MDR bacterial infections in the study is 23%, lower than studies in Iran, who reported 45%, and also Thailand, who reported 62%. The predominant gram-negative isolates from current study is Klebsiella pneumonia, followed with Pseudomonas aeruginosa, E. coli, and Acinetobacter baumannii. Meanwhile, Staphylococcus epidermidis is the most common gram-positive isolates, followed by Enterococcus faecalis. Bivariate analyses are used to determine the relationship between all of risk factor variables and the occurrence of bacterial infections by either using chi-squared or Fisher-Isaac test. All 5 risk factors are defined in categorical variables. There are 3 variables, which are volume of blood loss, loss in ICU, and biliary complications, which has p-value less than 0.25 and eligible to be in multivariate analysis. However, biliary complication with variable which biliary complication variable were automatically excluded by STATA program because it had a value of 0. This is the multivariate, this is the multivariate analysis. From this, subjects with intraoperative blood loss greater than and equal to 70 milliliter per kg and ICU length of stay greater than and equal to 20 days are at risk for bacterial infection within 6 months post-LT with adjusted risk ratio or ARR of 1.283 and 1.212. We also did analysis for MDR bacterial infection subgroup. The MDR infection and non-MDR infection group are consisted of 22 and 31 subjects respectively. We can see that loss in ICU and biliary complication has p-value less than 0.25 and eligible to be in multivariate analysis. Subjects with loss in ICU greater than and equal to 20 days are at risk of MDR bacterial infection following LT with ARR of 2.479. Shoji et al. Reported blood loss greater than 60 milliliter per kg is a risk factor for early bacteremia. Due to our center is still lacking than the Japan center, we use a higher threshold of 70 milli per kg. This also equals to massive bleeding in children older than 3 months old. Massive bleeding is associated with prolonged hypoperfusion and translocation of bacteria from GI tract. Patients with previous abdominal surgery and case portoenterostomy also most likely to have extensive adhesions that can cause intestinal perforation and massive bleeding. Indonesian patients were referred late to CMH and usually already having advanced cirrhosis at admission, that also increasing risk of bleeding during hepatectomy. Blood volume relies on anatomical variations, surgical and bleeding control techniques, and operator experience. ICU patients are often associated with HAI, especially by MDR bacteria. Longer duration of ICU stay actually depends on host factors, including immunosuppressive conditions, severity of liver cirrhosis, and complication of patient's underlying disease. Also, use of medical devices and also healthcare personnel behavior. Shortening duration of use for medical devices, in example, from previous studies, Foley catheter less than 7 days, CVC or central venous catheter less than and equal to 12 days, and endotracheal intubation less than and equal to 3 days, hopefully can reduce ICU length of stay. Compliance of HAI bundles by healthcare personnel is crucial because medical devices sometimes cannot be avoided, especially in some patients with poor clinical conditions. Mortality was found higher in children whose PELT score greater than 20 in previous study. The lack of association between PELT scores and bacterial infection post-LT in this study is consistent with two previous studies in Korea and Iran. Longer intraoperative duration was associated with worse baseline conditions and higher risk of biliary complications. Current study is consistent with the previous retrospective studies in Iran and Japan, but has different results from Pichapap et al., who conducted the study at Thailand and reported that prolonged surgery as a risk factor for gram-negative MDR infections. This discrepancy may be due to CMS center is still developing. We only began solo operation since 2018, and also Pichapap et al. Use a different group from our study, which is it just used gram-negative MDR infections. Biliary complication, including bile leaks, occur more frequently in LDLT, ranging from 10 until 30%. And bile leaks was a significant risk factor for bacteremia within 3 months post-LT from previous studies. The gap with our study is perhaps caused by our sample size is too small. Limitation. This is a retrospective study that relied on secondary data and medical record documentation with a limited number of subjects. The gap of total subjects between two groups is quite large. Since this is a preliminary study, so risk factor variables such as ICU length of stay, intraoperative blood loss volume, and biliary complications can be examined in future studies with a better study design. Conclusion. intraoperative blood loss volume greater than and equal to 70 milliliter per kg, and ICU length of stay greater than and equal to 20 days are identified as risk factors for bacterial infection in the study. Shortening ICU length of stay can be achieved by reducing the duration of use of medical equipment. Increasing awareness among healthcare providers about adherence to HAI bundles is expected to decrease bacterial infections post-LT at CMH. Early diagnosis and prompt referral of chronic hepatobiliary diseases, timely surgery, and refining surgical techniques may improve post-liver transplantation outcomes. This is the end of my presentation. Thank you so much for listening to me speaking. If there is any questions, I will try my best to answer that. Thank you.